Good morning. Today we're going to be speaking about lung cancer. The World Lung Cancer Day was actually yesterday. Thank you, Dr. Agbakwuru and Dr. Adewoyin, for coming on the program to talk about lung cancer. Lung cancer is actually a terrible condition that unfortunately is something that people don't really know about here in Nigeria. So Dr. Agbakwuru, can you just tell me why? Why is it that people think that lung cancer isn't really a problem here in Nigeria? Is it? Is it really?
Thank you so much for having me on the show. I'm glad to be here. So the first question was, why is it that people don't know so much about lung cancer? Well, that can come from two different angles, from the patient side of it and from the physician aspect of it. So most times we don't really understand that these things are actually clinical entities that people in other parts of the world have to deal with. So from the physician part of it, we don't have so many specialists who would help to get a diagnosis. So it's a bit of a diagnostic dilemma. And before you realize that the person actually has lung cancer, the person actually have passed. So it's important to understand that there are risk factors that could lead to this entity and be able to recognize the signs and symptoms that could help you make an early diagnosis so the patient can actually receive the best care.
And then from the patient perspective, you explain from the physician. Yeah.
So from the patient perspective, we have to actually take those notes we see on cigarette packs seriously. When you see smoking kills and you see the Surgeon General's warnings, those things were written because they're actually true. So when you look at the war in advertising and the bans that have come with smoking and all that, you realize that, the whole world is sitting up and taking the issue of lung cancer seriously because its most commonly recognized risk factor is smoking. So people really have to understand that when you have an unremitting cough that's productive and you realize that you've gone to the physician and they've ruled out tuberculosis and they've ruled out other infective causes, you need to look closely. Instead of going to some charlatan or unorthodox place, you need to go to your physician and actually have yourself scoped out and have a biopsy done.
Now, before we go into details about scoped out, can you talk a bit more about the risk factors that people need to be aware of? And for my personal question, what about all this vaping and all these e-cigarettes and all that? Are they a risk too? Or is it just only the normal cigarettes that create a risk for everyone?
Okay, so vaping is actually like way worse than just normal smoking because it's an artificial type of delivery. To be able to convert the nicotine into the vapor, there's an extra chemical that's put into it that helps you to deliver it in such smokeless fashion. And what happens is that in addition to the risk that you're getting from having these toxins in your epithelia, in your bronchi, you actually have that extra chemical that helps to deliver the vaping. And it leads to a new type of respiratory ailment. I can't remember the acronym. I bet a pulmonologist would, but it's called vaping-induced broncho. It has something to do with the bronchi. So it's actually terrible. And it's been one of the major causes for emergency room presentation by young people recently. So vaping is way worse than smoking. And that's not to say any of them is any good at all. But coming down to the risk factors, just like you asked, the most common risk factor. So now you're asking about a risk factor, I have to divide them into two different entities when you talk about lung cancer, because they don't have the same behavior and they don't have the same outcomes. So as a clinician, when you're talking about lung cancer, you have to be able to discern into two. So are you talking about small cell lung cancer or are you talking about non-small cell lung cancer? So I don't want to give too much information that will overwhelm us, but it's critical to understand that small cell lung cancer has a very awful prognosis. Our pathologist will probably tell us more about that. It's so bad that the diagnostic dilemma would even confound the doctor so much that before you even get a diagnosis, it's already at a locally advanced to metastatic stage. The more conventional lung cancer that we know and deal with, the non-small cell lung cancer that has a variety of others in it. So smoking is also a risk factor. You have occupational exposure sometimes. You might have occupational exposure to some metals and some chemicals. You know, there's asbestos that has been closely linked to mesotheliomas and some type of lung cancers also. Then there's been, I don't know how common this is in Nigeria, but you know, the way American houses are built, they have a lot of contact with the earth itself. So you have your basement, from which you have the first floor of the house, and you have the upper landing of the house. So they have a lot of radon exposure. Radon is a naturally occurring radionuclide. So it's been found that that has contributed a lot to risk factors with lung cancer. So basically smoking and, you know, chemical exposure, occupational exposure, but at the very top of the pyramid is smoking.
What about the shisha pipes? Because a lot of people think that doing shisha and doing all the other things removes the risk of lung cancer and other things.
So maybe I should rephrase from smoking to combustibles. Let's just say combustibles. Secondhand smoking, firsthand smoking, however you're delivering it, as long as you're having those combustibles and you're inhaling combustibles, you're putting yourself at risk, not just for lung cancer, which sometimes might be even a late case sequelae, but for immediate respiratory ailments that would happen in the here and now. You could have sudden closure of the bronchi, and you can have emergency room presentations that hasn't even gotten to lung cancer yet, but those things are really, really dangerous, and we need to bear that in mind.
Okay, so those things that really should be avoided. Now, you also went on to talk about diagnostics. You talked about scoping. You talked about, you know, getting a diagnosis promptly. Can you explain what is scoping for our lay people who are listening, so that they know what they should be looking for or asking for, and you know what happens when a scope is done?
Okay, just like almost every cancer, when you're managing in oncology, we don't manage on our own. It's always a multidisciplinary approach. So when you meet a case that you're suspecting for lung cancer, you have to bring in the cardiothoracic surgeon, you have to bring in the pathologist, and you also have to bring in the ear, nose, and throat specialists, or the ORLs, the otorhinolaryngologists. So those would help you obtain a sample from, because I mean, you view it, you do a CT scan, or in some places that are more resource constrained, you do an X-ray. But ideally, you should do a CT scan. You see a mass on the CT scan. So how do you approach the mass? Because like I said, you have to discern if it's small cell or non-small cell, because they are very different in their behaviors and their treatment and their outcomes. So once you miss it at that point, there's no way you're going to get good outcomes for the patient. So the most important part of management of lung cancer, I would say, is the diagnosis. You have to get an accurate diagnosis. How do you get an accurate diagnosis? You have to get a sample, which is what you call a biopsy. That's a sample from the living tissue, which is where bio comes in. So the only way you can actually get some sample, it's not the only way, but the most common way that most of the ORLs use is to use a scope. So that could be a bronchoscopy. You could do a fiber optic bronchoscopy. They'll give the patient some kind of mild sedation and pass a scope through the nostrils, and it will go down into the trachea and into the area where the trachea bifurcates into the bronchi. Wherever the mass is, it gets a piece of the mass, not all of it, just a little piece, enough to get some diagnosis, histology. It come out, and it's a very short procedure. It's in and out. It doesn't require admission, and it's very widely available here in Nigeria. So that's the first step.
And certainly available at the LUTH NSIA Cancer Center where you are.
We have access to all the specialties because we are based in the teaching hospital. So yes, it is available. We can get that done.
Wow, I think so. We have so many questions though. One of the questions is, who is, you know, more prone to having lung cancer? Is it more common in women than men? And what are the kind of symptoms that a person should look out for, particularly if they smoke?
Okay, so there's something interesting about the epidemiology of lung cancer, and that's something I have a lot of interest in, because thoracic malignancies, there's something of an area of specific interest for me and subspecialty. So noted that back in the days, maybe let's say about 25 years ago, it was noted that the adenocarcinomas which are a type of non-small cell lung cancer. They were more common in women, and the small cell lung cancers were more common in men. But as the years have passed, it's been noticed that the predilection, the gender predilection has almost been erased completely, and it's almost at a one-to-one between the both of them. Now, people have said, is it because women have started smoking more and men have started smoking less? There are a lot of arguments for that, but right now, I can't say which is more common in the genders, but there's always a slight disparity in terms of small cell lung cancers and men, perhaps because of occupational exposure, or men are heavier smokers. But the long and short of it is that lifestyle changes have happened and women are smoking more now. So there's a shift in the clinical entities you see in both genders. And as for risk factors,
what kind of symptoms do
okay,
we
yes,
expect to see?
I thought you said risk factors. So symptoms, sometimes, just like almost every other condition, you may be asymptomatic. Asymptomatic means it might be an incidental finding. You might just go to the doctors, or you might go for an employment check, and they do an X-ray and they see a mass. And when you start investigating it, you find out that it's lung cancer. But almost commonly, you tend to have weight loss. There's going to be some weight loss, because lung cancer tends to happen with a lot of what we call paraneoplastic syndromes. It's one of the most implicated cancers in paraneoplastic syndromes, which means that apart from just the presence of the cancer itself, there's so many metabolic things that are going to be going on, breaking down, building up, and tearing up all over the place. So weight loss is going to be in there somewhere. A cough, of course, because we're talking about the respiratory tract, and the cough might be dry, it might be productive, but in most sinister fashion, sometimes it might have bleeding in it. So that tells you that there's been some invasion of a blood vessel, or there's a local invasion there. Then depending on the extent, now you start to have symptoms depending on the areas that it may or may not have spread to. If it has spread to the back, you might have back aches. If it's spread to the back seriously, you might have, inability to stand up straight and walk. And sometimes in the small cell lung cancers, the thing about them, why they're so devilish, is that they are one of the cancers that love the brain more than anywhere else. They love to go to the brain. Other cancers will go to the bone or to the liver, but these guys, before you can say anything, they've already gone to the brain, which is why part of the treatment for these patients is prophylactic brain irradiation. Once you see them and you've treated them, you have to do a brain irradiation. So sometimes they might come confused, having memory loss, and you see symptoms that...
Good morning, Dr. Adewoyin. It's a pleasure to have you once more on the program. Thank you for coming.
Thank you. It's a pleasure to be here.
Now, we're talking, and Dr. Agbakwuru spoke, quite succinctly, and said how important diagnosis is, how important pathology is, and how important the fact is that, oncology is a multidisciplinary subject. So can you tell us from your perspective, what are the important things, just simply put, that our listeners need to know about diagnostics in this case?
Yeah, thanks for the question. So diagnostics play a very crucial role. Of course, before you go on and treat an entity like cancer, you need to have a very clear diagnosis. And for you to achieve that clear diagnosis, of course, it all begins with the clinical information that is provided to the doctor. So sometimes it could be asymptomatic, like Dr. Chidi mentioned. Then beyond that, there are some suspicions that will go through the doctor's mind based on the kind of symptoms and signs that you present with. And then the doctor, having a suspicion, will want to have some level of confirmation. So that warrants taking a biopsy, and that requires getting a representative sample. So that's where we talked about bronchoscopy. Now that sample needs to go to the lab, and that needs to have an histologic examination of the specimen. So there is some microscopy looking at the visuals, looking grossly at the specimen, and then some microscopy, which is histology, to characterize the kind of tissue that is being seen under the microscope. But beyond this basic histology, there needs to be ancillary investigations to be able to type further. So these ancillary investigations are able to help delineate in specifics what kind of cancer, what kind of lung cancer we're dealing with. Is it a small cell? Is it a non-small cell? Because all of these have implications for treatment or for therapy. So beyond that as well, there are still investigations like what we call the immunohistochemistry, where we direct some immunostains to different kinds of antigens on the lung tissue. And that helps us also characterize the lung cancer better. Now, so that's about making a diagnosis. Now, beyond making a diagnosis, you also want to prognosticate. You want to look at the outlook. So some of these lung subtypes, the cancer subtypes, they have their different outlooks in terms of prognosis. So that's immunohistochemistry, which is when we direct some immunostaining against antigens on the lung tissue, helps us to further characterize. We also do genetic studies. So there are different ways around that, but there are very advanced methodologies now where you can actually multiplex and be able to look at different gene targets in that tissue so that you can look at what is the genes or what are the genes that are driving the kind of tumor or the kind of cancer that you're seeing. And I mean, generally in the realm of cancer, we talk about the oncogenes, we talk about the tumor suppressor genes, and then mutations affecting them, driving these tumors or cancers to grow. So the common ones you get to hear about in a condition like lung cancer, you hear TP53, you hear the KRAS. Of course, these are not they are not specific to lung cancer. So if you're talking about colorectal cancer, you hear the same thing like KRAS mutation, you hear EGFR.
You're being a bit technical, Dr. Adewoyin. People who are listening are lay people, so just you can make it a bit simpler.
Right. Yeah. So to make that diagnosis, we talked about histology. We also talked about characterizing the kind of lung cancer further, where we do some auxiliary investigations to be able to tell what kind, in terms of real subtyping of the tumors. And then we also talked about
why is it important? Why is it important? Because you're talking about going deeper into ancillary investigations to do subtypes. Why is that important? Why do you need to know it? What benefit is it of it to the patient?
Right. So when you have the specific subtype, it helps to determine the treatment and to plan treatment. So there are treatments that are given based on the kind of genes that you also have driving. Take, for instance, you have the lung cancer being positive for something like A2. Then you can get a drug that can directly target those lung tissue, those aberrant tissue expressions because of the expression of that particular kind of abnormal gene or abnormal antigen on this lung cancer. So it helps to direct treatment too. And so you can really focus your treatment. So it really points to individualizing care. You can really focus on, oh yeah, this is the real biology of this kind of cancer, and then you can direct your treatment. Like I mentioned too, it helps to prognosticate. And again, the other good thing is that when you have this biomarkers, you can also sort of monitor response to treatment. So if, for instance, you have a 70% tumor expression, and then down the line you're getting treatment, and then you are getting a 10% tumor expression after 3 or 4 cycles, that improvement, that's achieving significant improvement that you can really track. So those are very good benefits. You can really define your diagnosis too. You can prognosticate in terms of looking at the outcome. And then 3, you can really guide your choice of therapy because you can then individualize care and direct specific treatments that will benefit the particular patient. And of course, you can also monitor response to therapy when you are able to identify these biomarkers.
Thank you. Thank you very much. That's very useful. Now, Dr. Agbakwuru, we have some really important questions that have come through. The first questions are that, number 1, is the tumor or is lung cancer specifically a risk for people with the following? 1, people who smoke cigars. 2, people who smoke e-cigarettes. And 3, people who smoke weed. Dr. Agbakwuru.
Thank you so much for putting me on the spot. That's very kind of you. That's very kind of you. So I wanted to first of all, I want to start by adding to what my colleague just said, and he was spot on. Another reason why it's important to do those tests he talked about is to save money also. You know, we're paying out of pocket in this part of the world. You can't afford to be treating the wrong entity. So you're saving money for everyone also. And back to your question, I was just trying to do anything not to touch on that question, but back to the question. So you asked if these things are risk factors, you know?
Honestly, because the reason why we have to do it is people with cigars, they tell you, oh no, we're not inhaling, we're not part of it. People with who smoke weed, people who are on e-cigarettes, actually I think they're totally immune from it because it's an e-cigarette. Those who are smoking weed believe it's a cure-all for everything. So we need to address all of these three.
Okay, so there's a psychological defense mechanism behind all these statements you just talked about now. For example, people who smoke cigars, they pride themselves in the fact that cigars are expensive, cigars are hand-rolled, and cigars come from the best leaves that are farmed in the best mountains in Colombia, and it's a status symbol to hold a cigar. When your friend comes over, you open your cigar box and you give him a cigar. And yeah, kudos to them. They don't get to smoke one cigar in one sitting. They smoke it over several days, but you're still smoking. We talked about the last part where I had to, you know, paraphrase completely and stop using the word smoking and combustibles. There's a reason why they say secondhand smokers are also at risk. Imagine if just sitting by somebody who smokes, you're still at risk, and talk less about actually smoking. So vaping, cigarettes, cigars, they all put you at risk because you're introducing what we call nitrosamines, the end product of, when you're talking about the carcinogenesis, I don't want to get too technical in it, but when you're talking about how the cancer starts, that's something you learn in postgraduate medical school. How is it that smoking turns to cancer? So you would hear at some point, they will tell you about nitrosamines. So nitrosamines start the carcinogenic process in the bronchi. So all these three things you mentioned here will end up generating some level of nitrosamines. And yes, I mean, I have to talk about the weed smokers. You know, it's something I didn't want to talk about. You know, it offends the sensibilities of so many people. But the reality of it all is that, you know, in as much as there has recently, in the past couple of years, been an argument for medical cannabis, but still smoking marijuana, as long as you're smoking marijuana, you can't con yourself into believing that you're not at risk for lung cancer. You are at risk for lung cancer. There was actually a study I saw a while back. I think that was like a couple of months ago. I can't remember exactly, but I think it was in the Lancet. And they talked about the risk from smoking marijuana and smoking cigarettes almost equalizing at some point. So that's something we need to look up. We can't live in denial anymore. There is a risk. There's a risk. It's up to you to make the decision as an informed adult, but there is still the risk for lung cancer, if not the same as regular cigarettes. So
thank you so much. We actually have run out of time. This has been a very interesting, very exciting conversation. But so I just need you to, in under 30 seconds, to give me your last words for our listeners.
Okay, so I think from the risk factors we talked about, I would recommend risk reduction. Anytime I talk about cancers, I always try to stop at the end. For those that you can't screen against, because you can't screen against lung cancer, you can't go doing CT scans every year. So the best you can do is risk reduction. Occupational exposure, stop smoking. Your partner, you have to tell them to stop smoking, and to make sure that you're building, I mean, that goes without saying, the building materials in your house are not made of all those old school materials like asbestos, which would put you in danger perpetually. So that's all I have to say. Risk reduction is very important. Dr.
Adewoyin, your last words, please.
Yeah, sure. Yeah, so I think for me, it's important to just emphasize to our listeners that accuracy of diagnosis is very important, and that biomarkers are available for us to be able to also guide the choice of treatment as provided by the physicians. And then these treatments or these diagnostic markers are available and they are locally available and can be assessed. Thank you.
Thank you for watching. Please like, share, and subscribe for new video updates.